how's Naomi doing?
She's been having a PT coming in. I've watched her move around the house, and she's moving with some pain, but more grace and nimbleness. Her voice is strong. She says that as they've been doing the lab work, the potassium has been at like 130, which is not 135, but 130 is better than 112, which was really the problem. And she said her potassium is right. So between her potassium and sodium, those sound like the big.
How about, have you got BUN and creat? BUN and creat, blood urea nitrogen and creat?
I don't know.
All right. Also,
but she's convinced she doesn't need kidney replacement. And so while she absolutely hears the idea that being part of the Leahy health system would help with that, she's not perceiving that to be a need.
Also, would you mention to Rebecca that I'm still here? If
She's never contacted you?
No.
Okay, so sometimes
Yeah,
she just doesn't do shit. I mean, which is so
Dad,
weird.
it's okay.
Yeah.
Just say, bumped into Jeff Dalloway.
Yeah.
He's looking forward to chatting with you.
So her car's been sitting in my driveway for over a week. All she has to do is use the AAA card I gave her for Christmas. Call AAA and tell them to come replace her battery.
Okay, have you tried charging the batteries?
Yes.
And that doesn't.
AAA came once before, and instead of doing a permanent fix, they jumped it.
No.
And she drove it around.
No.
So you mean a deep charge?
A trickle charger would do.
I have never had success doing that. I just haven't. And
Yeah, they vary.
I'm really old, so I've had to try it a lot. So sometime about a decade ago, I just got to the point where I just said, replace the damn thing. If it's over 18 months old, just replace it.
Okay.
Yeah. And so
I have to look at this for a couple of minutes.
go for it.
And we have to schedule a meeting.
Yeah. I wanted to complain about the pH.
This is the Legislative DHHS Oversight Committee for Friday, January 28th. Would the clerk please call the roll? Here.
Here.
Here. Thank you. First agenda item is the minutes for the meeting of December 17th. You have all received copies. Any comments? Corrections, emendations?
Move to approve.
To approve by Senator Gray and seconded by Senator Rosenwald. Any further discussion? All in favor?
Aye.
Opposed? Thank you. The agenda item next that I've been given discussion on the establishment of a subcommittee regarding House Bill 1616 FN. This came to my committee, Health and Human Services. One of the difficulties we're working under presently is getting people to staff committees that are appointed to study items. The Speaker has not only asked me to try to fill such positions regarding Health and Human Services increasingly, I've been asked to try to fill any positions, making recommendations on who would be a good fit. So I can tell you it's very, very difficult. There are some people who do not want to serve or cannot for various reasons. There's other people whose skill sets are wonderful, but in different areas than this kind of work. And then that just leaves the people who are already on multiple of these committees. And I've gotten turned down most wonderfully by so many people because they said, I'm already on 5, I can't do any more. So the word is coming down, and it is seconded by my colleagues across the aisle in the House that if possible, can we go a different route other than appointing a specific committee of House members and senators. And I hear senators are appointed to a lot of different committees too. And we'll see what we can do here. So it was suggested to Representative Yokela that perhaps we could go in a little different direction to get people in an ad hoc working group that would come back and make good recommendations. I, as chairman of Health and Human Services, have also, in a parallel track, asked 4 members of my committee to brainstorm, come up with some ideas, not in a formal way, but see if they would recommend some good things too. So I would recognize Representative Yokela to come up and speak to his idea. And he'll tell us why this bill has importance to it and perhaps how we should go forward in changing laws or making recommendations for changes to statute. Somebody who's techie, help him turn on the microphone. Somebody who isn't techie but has done this before.
There you go. Mr. Williams to the rescue.
And you got to be fairly near to the microphone, please.
So Mr. Williams, could I suggest maybe moving that mic over? Oh.
You can go over there if you want, sure. Channel 9 will get a better shot of you.
Yep, that one turns on.
Yes, sir.
Thank you, Chair, for bringing this before the committee. My bill stems from finding in our current laws that essentially in a bunch of situations, minors having syringes, needles, injectables like EpiPens that they don't have a prescription for is currently illegal in New Hampshire. And I gave testimony as to a number of situations, someone, doing cleanup around their town, a friend showing them how to use the EpiPen that they've newly been prescribed. All of those may cause, currently under our law, those people to be committing a crime. And one of the things that we are trying to do right now is not, one, change that we don't put kids into the legal system unnecessarily, and two, to treat, if there was some nefarious reason why they were having this, it not in a legal sense, but as either a mental health or a substance abuse issue and not a legal issue. And so, so the first part of the bill is to repeal that restriction on minors, but then there's the there's a separate section of law that says if you've provided the needle, syringe, EpiPen, auto-injector to a minor, then that is also a crime. And I wanted to look into that and see about exceptions. So I proposed a study committee to look into that issue instead of, suggesting my solution to that problem. And so it was suggested at this committee hearing that one, I do my own research to try and come up with some language, and two, to form an ad hoc committee and or a subcommittee of this committee to do more research so that this issue could be addressed more comprehensively in the near term and not push it out for too long. So since then, I have reached out to the New Hampshire School Nurses Association, camp counselor, or camp nurses. I have reached out to DHHS because we have in New Hampshire a syringe program that doesn't specifically say that it offers syringe services to minors, but it is not forbidden. And there are states like I found North Carolina offers syringe services to anyone. And one of the reasons why we do that is the CDC has suggested that trying to limit the syringe availability has caused bloodborne disease problems, and so we don't really want to move forward with that. And so there's been an effort to make syringes not reduce the prescriptions for adults, which has been done in a lot of places, and just have more availability. And so I've reached out to a bunch of people, and I've proposed, and I've come up with what I think may be a proposed amendment for the adult language.
Okay, the amendment would not come here. It
Right.
would come to HHS and
Right.
EA. However, my question is having to do with the study committee for
Right.
reasons already given. It might be a better ad hoc group of people who meet. Often bills come to us out
Sure.
of those. And so are you suggesting that that would be a better way, something that would be a work group, perhaps as a subgroup of us, with one of our people being part of that, and then others that we've pulled together?
Yes, that we would be, if we had some representation from this committee and or the Health and Human Services Committee, to be able to talk to some of these people and
Okay.
the ideas
Okay.
that come forward. Yeah.
Anybody from the Oversight Committee wanted to weigh in? Representative Edwards.
Thank you, Mr. Chair. I'm empathetic with the issue as you've described it. I am personally a little confused because I have an understanding of how policy committees work and how oversight works, and I don't understand what an appropriate response would be to you in this situation. I would tell you that personally, I don't get really busy for another 2 to 3 weeks. So if we can knock this out quickly,
Absolutely.
I'd personally be happy to do it.
Great.
Also, if you're thinking about ideas of where you could turn to maybe get some input, right now the Governor's Commission on Alcohol, Drug Abuse, Prevention, and Treatment is meeting, and Patrick Tufts might be a good person. I can give you the contact information to just give you some advice on somebody on the commission that might want to participate. And because you have such a great room of experts here, maybe somebody will grab you and say that they'd like to participate, like I see Moira back there, child advocate, you know, so, all right, so I guess that was the purpose, was to try to find some people that might ad hoc with him?
No, yeah, but the real purpose is, should this be a committee out of Bill 1616 as it's written? And we're going to probably say no in the committee for simply the reasons of staffing. Or should this be simply an ad hoc group of people you pull together? Or could it be an ad hoc group of people that maybe finds a little home coming under the umbrella of us for a brief period of time? Those are the options we have. Doesn't have to come out of here, could be on your very own, but it might be also possible to come out of this oversight committee. Anybody else with any thoughts? Representative Marsh.
Thank you, Mr. Chairman. I don't know if this is working or not. Turn on like they do in our committee. Back when I was a first-term representative, we passed the syringe service program, Senate Bill 243 in 2017, I believe. These are the syringe service programs are entirely unfunded by the state, and I think any mandate on these programs would, first of all, be an unfunded mandate, and second of all, would interfere with the mission of the syringe service programs, which is specifically to reduce the spread of some pretty severe infectious diseases amongst the vulnerable population. So I would be very much opposed to this going forward.
I don't think, Representative, that that's really where he's going. He would just like it possible for somebody to have an EpiPen. It's really more along that than anything else, but.
I did reach out to some of the syringe services people and the people at DHHS that run the syringe services program, and to ask them if they had the ability or currently had the desire to be able to serve that population, the under 18 population. It isn't a big population because that's usually using syringes for nefarious reasons is happening later in life, like 20s plus. But there are, the question that I pose to them is, should we be forbidding them from doing that if they had the funding to, and someone asked for their help, would they be opposed to that? And so that's one of the discussion topics for giving them an exception to be able to service those people, but it's not a mandate, definitely. Thank you.
Any further question on whether we should, with one person from this committee, work with Representative Yokola as a subgroup of us? That's the issue before us. Anything further? Yeah.
So to that question,
That is the question.
of whether Oversight should take on a role of mentoring or sponsoring a work group like this, I would just say I don't know that there's a precedent for that, and it just doesn't feel right to me from an oversight position. I think what is being asked is more of a policy committee issue and not what this committee does. So I'm not opposed to what he's doing. I'm just trying to think functionally if this is the appropriate committee, and it doesn't feel to me like it is.
Anyone else? He does have the fallback position of being able to pull a work group together on his own, and I've already, as I said, have 4 people from Health and Human Services Committee looking at this issue, and
Beautiful.
you can pull them in if you wish. It doesn't sound like we have the votes to do this, but now we're aware of it, and
Sure.
I'll work with you on that other alternative, okay?
Sure, thank you.
Thank you.
Absolutely.
Yes, sir.
Senator Gray, I was the sponsor of the syringe exchange program, you know, that passed. And there's many issues. I've tried.
We do have a techie guy right here.
Well, But there's many issues that go along with that. And you know, like even in the city of Rochester, there were complaints about the syringe exchange program that was going on there and the policing of it by the people who were taking advantage of it. And I agree with Representative Edwards that a policy committee is much more equipped to deal with that. Our job is to say, well, certain things have been passed and we're going to see that they are implemented rather than try to craft a bill. So, thank you.
I think we have our answer, and I'll be back with you, Representative. Some good ideas here. We just got to get them in the right place. Thank you. And, okay, now on the agenda, and sorry, not sorry that it's now on the agenda, but sorry for you getting bumped down, is Commissioner Shibinette. Mr. Technical Person on the floor, has the mic at the speaker's place been replaced? Okay.
This is okay. I don't want to have my back to anybody. So I just want to give a brief update on a couple of key things going on in the department this week, next week, in the coming months. Under COVID, right now we are evaluating the data that we're using as we move further along through the pandemic, and we rely more on at-home testings, things like that. Data points like active case counts become more unreliable as we move to more of an at-home testing base. So over the next couple of weeks, we are really going to be looking at the data that we're reporting and what is valuable, what's a value add to both tracking and our response to the pandemic. I think when we know that, you know, our case counts, for example, we're reporting 2,000 or 3,000 a day, it's probably double that, right? Mm-hmm. So we just ordered 1 million more at-home COVID tests, the antigen tests that will be sold in liquor store for cost. So as we rely more and more at the at-home basis, we don't want to give either a false sense that cases are going down when they're not, or that there's really 3,000 cases a day when it's maybe 5,000 cases a day. So I think what you're going to see is probably a new component of data coming out on what's driving our response. It's mostly going to be around hospitalizations and fatalities. It's not that we're not going to report case data, but we're going to become less reliant on it. So that work's being done over the next couple of weeks. As I said, we ordered 1 million at-home tests. We got approval to order 1 million at-home tests on Wednesday. We expect them to be in the state in 7 to 10 days after the order is placed, and then after a couple of days of processing by the Liquor Commission, they'll be in our liquor stores for sale at cost plus the cost to distribute through the Liquor Commission. In the prior month, we've stood up 2 strike teams in long-term care facilities, one at Premier and one at Ridgewood. We have a third one coming on board, Edgewood, on February 7th, and then we have a rehab strike team that we got approval for on Wednesday, and at the previous fiscal meeting to do a rehab strike team that's coming on board February 14th. So far with our long-term care program, where we're trying to move long-term care residents out of acute care hospitals and back into a long-term care setting, we have moved 64 into county facilities with the guarantee that their Medicaid would be covered. And we've moved 62 into these strike facilities. So total, approximately 122 people we've moved out of hospitals and into in a more appropriate environment. That's it for COVID. Under mental health, we're expecting IMD approval. So the waiver that we submitted last year, we're expecting that in the spring of this year. The intent on applying for this waiver was to attract private behavioral health providers to our state so that they can run both inpatient and outpatient capacity. We are hoping to bring 2 projects forward in the coming months to build our inpatient capacity in our state through public-private partnerships with a couple of different entities. So we're still working through some of those details, but hopefully in the coming months, we'll be able to bring those to the table.
Representative Marsh.
Thank you, Mr. Chairman. I don't think my mic is working yet either. And thank you, Commissioner, for coming before us again today. Well, I grant that there's clearly issues with the data that's being presented with in-home tests. I think that the New Hampshire citizens clearly have an interest in the prevalence of COVID in our communities. 2 years ago, I asked DES if they would look at a wastewater monitoring program, as they've now implemented in Boston, because that gives results as to what's going on throughout the state or throughout the area of their wastewater system, and that has shown both the rise and the fall of the Omicron variant in the Boston area. I do believe we have a number of wastewater systems where that can be implemented relatively quickly and inexpensively in the state of New Hampshire, and I inquired a couple of weeks ago from DES if they would consider such a thing. I've not heard back from them. Would the department consider doing something like that instead, so we continue to have some data as to the prevalence of COVID-19 in the state of New Hampshire?
We've used wastewater treatment programs in private areas, right, like New Hampshire Hospital monitors their COVID in their hospital based on wastewater tests. And UNH conducts those. So I can connect with UNH and see if there is interest in expanding their programs. They've done wastewater treatment testing for their campus, for a variety of nursing homes, for the hospital. So the science and the testing is there, obviously. I just want to make sure that we're connecting with the right people to see if we can do that. And are there municipalities, cities that are interested in it? You know, is the city of Concord interested, or city of Manchester, whomever? So let me connect with UNH and their wastewater program and see what their ability is to scale up their program.
I thank you for that, because I think our citizens need to know what the prevalence of COVID is in the state of New Hampshire at any given point in time, because they make decisions based on the data that you are reporting.
I agree with that, but if I'm reporting inaccurate data because there's thousands of tests being done at home, then I don't want to give the public a false sense of security. And
I agree with that as well, but I think we need to, if we're going to eliminate one thing, we need to replace it with something else.
Would it be possible, when giving the number of positive test results, there's an immediate statement, a disclaimer saying, we believe this number to be artificially low because of the proliferation of home tests, the data of which are not reported?
yes,
You know, sort of like the Surgeon General's warning on a pack of cigarettes.
yes, we've used that messaging pretty regularly throughout the last couple of months as the insurgent of home tests have come out. And we will still continue to report case counts and tests. But what we don't want is, as thousands of people in New Hampshire start doing at-home tests, for them to feel like they have to call public health and report they're positive, because we don't have the resources to do that either. So we will still continue to report case counts, but we're going to pull in other data that I think is going to be more accurate than the actual counting the number of cases in the state.
We have told our patients at our center in Kingston, if you test at home, please send us the results. We'd like to know. It's helpful in our care review.
Absolutely.
I want to thank the commissioner. The Vax van came to our facility in Kingston the other day, and combination of what the Vax van people have posted on websites and lots of publicity from me, we had a lot of people come. It was wonderful. People didn't have to come, but if they wanted to, it was right there in our parking lot. So thank you.
Our mobile clinics have been very successful across the state, probably one of our more successful programs, really meeting people where they are, getting into vulnerable populations, people that don't have, you know, widespread transportation to get the vaccine sites. They've really been quite successful across the state.
And also especially when the local group that's sponsoring it is a group of people that are trusted by the general population, so that, well, if Dr. Pearson's for it, I guess it's okay.
Yes.
That really worked well
Yes.
for my wife's patients. Also want to thank you about the increase in caring of mental health, the addition to the facility here in Concord, the purchase along the way, we hope, of Hampstead Hospital, the partnership with Portsmouth Hospital, and a new facility in Epping. It's gotten to the point now when I pick up the Union Leader in the morning to read it, I'm wondering, what's next? Because you're really doing a wonderful job in getting more space.
Thank you. I think, we're trying to build out the system of care fairly quickly. We've had an ER boarding crisis for a decade now, and we've spent 4 years building out community-based services. We've launched our CTI program today. There are rapid response programs, crisis services, mobile crisis services, and you get through the continuum and you get to that peak, which is the most expensive and most acute part of the continuum, which is the inpatient beds. And when you look at national studies, they'll tell you that inpatient beds per 100,000 should be between 50 and 60 beds per 100,000 of the population. New Hampshire is currently at 38 if we used every bed that we had licensed. For example, Hampstead is licensed for 111 beds, they're only at 45. New Hampshire Hospital is licensed for 192, they're operating around 170. There's a variety of reasons for that. So with the Portsmouth deal, as we bring that forward, that would bring our patient bed load up to about 40 per 100,000. A second project would bring us up around 44, 45, which is still at the very low part of that threshold is what is considered acceptable. So we're excited about bringing new beds online to support the people that are in the emergency rooms. They are not to replace the robust community-based continuum that we have built for the last 4 years to help support people in the community. That's where people belong. That's where people should get their first level of care anyways, is in the community.
Anyone else with a question? Senator Rosenwald.
Thank you. Good morning, Commissioner.
Good morning.
A few weeks ago, I had some conversations with department staff about the commercial urgent care centers, some of them being unwilling to bill insurance, telling people that their insurance wouldn't cover the testing even though they'd been exposed to someone who had COVID, so it should have been covered. Has that resolved, or are we still seeing people who are asked to pay a higher charge-based amount of money versus getting their insurance to cover it?
I haven't heard specifically about a lot of cases of insurance not covering it. We've actually talked to all the insurers who were covering it across the board, all testing and vaccination too. There was some question that as people started needing testing just to travel and things like that, it's not considered medically necessary. And I'll check with the insurance department to see if that jump has been made. I think, we have to differentiate the difference between going to a testing center that is supported and paid for and funded by the state and going to an urgent care center for an assessment of a respiratory illness, because they're two very different things. When you drive through our testing site, even though our testing site is being executed by Clear Choice MD, all of that is paid for by ARP funds. If you drive up to a Clear Choice MD urgent care center, apart from our state site, and go in, they are going to assess you for respiratory illness. Even if you just walk in saying, I want a COVID test, by their practice, they have to assess your respiratory status. So they're going to charge you for an urgent care visit regardless. So that's where a lot of people are getting confused. They say that they just wanted a COVID test and they went to somewhere other than our COVID test sites and they were charged as a visit. So that has definitely there's been some confusion in the public about that. We've tried to streamline that to say, if you want to test, no cost, go to our testing sites. If you go to one of the urgent care centers, apart from our testing sites, there is a possibility that you'll be charged your copay, it'll go through your insurance, and whether your insurance pays for it or not is going to be up to them. I can check and see if the insurances are still across the board paying for all testing. The last conversation I had with them, which was several months ago, they were across the board paying for everything, but I will check in with them again.
Thank you, because my understanding from talking with Dr. Ballard was that the problem was not with the insurance companies, it was with the for-profit urgent care centers wrongly telling people their insurance would not cover a medically necessary test.
Okay.
and they were charging some of them over $200 for a test. People could not wait for hours in a line for the free test sites.
So I'll check in with the urgent care centers too. We have two main ones in the state, and then we have our hospital-based ones, and it'll be pretty easy to find out.
Thank you.
Yep.
Anyone else? Representative Edwards.
Thank you, Mr. Chair. I think I have 4 different things I'd like to talk about. Good seeing you again, Commissioner. The first one it has a Part A and a Part B. I'm just curious if any of our testing and statistics gathering is making a distinction between Omicron and other variants, and if we are set up so that the next wave of variant is measured and reported distinctly from Omicron and Delta. It's something I could have asked offline, but I'm just curious what the precision is.
Yeah, so our public health lab does do genome sequencing, which can identify COVID variants, so they can identify Omicron. Now, a lot of our testing sites don't use our public health lab because that's very limited. But commercial health labs, LabCorp and those types, they are also doing genome sequencing for Omicron, as is the CDC and most bigger labs. So anything that comes to the public health lab, which are several hundred a day, we do genome sequencing, and we have been able to identify Omicron in our testing pool. When a new variant comes out, usually we are notified by the CDC that there's a variant of concern, and the CDC is the one that starts testing samples for it before it ever gets to us. But yes, once a variant is there, we can test for it at our public health lab.
And then are you reporting it distinctly, or are you putting all COVID together as though they're the same?
No, we report the number of variants. We have a weekly report that we send out.
Thank you.
Yep.
I have a follow-up. On the home testing, I'm curious about the accuracy of the testing. Do we have a sense of false positive and false negative rates on those?
Dr. Ballard can give you all of that information. Okay. He was on the committee that picked the test, and they looked at both the accuracy of the test. Most antigen tests are about in the same range, and ease of use, because that also impacts the accuracy of the test. So he has all that information. I can have him send it to you.
Okay, thank you. Mr. Chairman, may I have a couple? Okay. So I think this may be an opportunity for you to brag on your department. About a month ago or so, the Joint Fiscal Committee and the Executive Council authorized some funding for the booster burst, or I forget what the marketing term was for that.
Booster Blitz.
Blitz, okay,
Yes.
That's so much better than burst, I think. But the objective, the metric that you established for success, I think, was 10,000 boosters. Yes. Do you happen to know what your booster rate is?
So we had 2 booster blitz. During the first booster blitz, we were closer to 12,000 on that day. The second booster blitz, which was during the snowstorm, we had a storm that morning, we were right around 9,800. So for the most part, we met our objective.
Double is good. Double
Yes.
is a good success story.
Yes.
And then on the Joint Fiscal Committee, there was $12 million that was requested to buy the home test kits that would be sold in the liquor stores.
Yes.
And at that point, it wasn't clear that the process, procedures, the accounting system was set up so that as the test kit got sold at the liquor store, that transaction and that money would be flowing to replace the $12 million that we spent up front. I'm not asking you if you know right now, but are you comfortable that we're going to have that under control?
We have it. We signed an MOU with the Liquor Commission to have that money flow back into ARPA. And we actually talked about it at the press conference on Wednesday, that because it's going to flow back in and replace that money, that we can continually buy tests. You know, if we sell the 1 million tests, we'll use that money that is replaced and buy another 1 million tests. So we get to continue to make sure that the supply is there to meet demand.
One more.
Okay, so one last one. And this one may be something you've never heard about, but I had a very agitated school administrator call me, and the school administrator said that she had a full-time job being a school administrator before the pandemic. And since the pandemic, she spends, she says, literally all her time doing contact tracing. And so her frustration was that her other duties weren't being attended to, and so she was just asking the question, is there some money that the department may have to help supplement the manpower to do the contact tracing, or alternatively, if this data is not of the value of the cost of collection, can we change the collection requirements on school contact tracing? I don't know if you're prepared to speak to that, but I wanted to share with you that I haven't been in that intense a conversation in a while.
So that's exactly the type of data review that I had just spoke about in my update that we're doing. What is value added with all of the data that we're collecting? What was value added 2 years ago isn't necessarily value added today. So we're reviewing that now. Joint Fiscal just passed about a $9 million workforce, public health workforce CDC money, accept and expend. A good amount of that is money going towards workforce to help the schools during COVID. I'm seeing if Trish is here. She's not here. Public health isn't here. She has more details on it, but yes, that $9 million, a good amount of that is going to the communities to help with COVID, but we can get you more details on it.
Thank you so much, and thank you, Mr. Chairman.
Anything else for the commissioner? Representative Marsh.
Thank you, Mr. Chairman, and thank you, Commissioner. This is a follow-up on Representative Edwards' question about the booster blitz. I'm glad and that we've had some good progress in trying to get boosters out in the state of New Hampshire, but the CDC, as reported through Becker's Hospital Review, continues to report the state of New Hampshire has last among all the states in getting booster doses out, percentage of the population that has been boosted, or as is the new term, up to date with vaccination. Would you like to comment on any efforts the department is making to address this problem? Because clearly, if we're not up to date with vaccinations, we're not protected against the current variant associated.
Yes, we agree, and we continue to message every week for people to get their boosters. In addition to Booster Blitz, we have our mobile site that's going around to all of our vulnerable populations. We have a homebound program we've just contracted with to deliver booster vaccines to the home. We have stood up 6+ vaccination sites across the state to do both primary and the booster doses. We're making vaccines available, and you know that's our role. We have to make it accessible. We have to do the public campaigning to say this is what you need to do to protect yourself. I haven't seen Becker's recently, but I'm going to go look at that article. I think part of the issue with our booster data is the accuracy of it, because we don't have a robust IIIS system. What was happening is CDC could not distinguish between first dose and third dose. So they were, when you look at their reporting, you would see a very high initial vaccination rate, very low booster. And what the reality is a lot of those initial vaccinations are actually the boosters, and the CDC doesn't have that information because we don't report patient-specific information to the CDC. So a lot of the national data, until we fix that IIS, can be confusing.
Follow-up.
Follow-up, do you have any plans going forward to fix that so we'll have an accurate idea of where New Hampshire sits as far as having our population up to date in vaccination?
Yes, we actually, a lot of our fixes for that came forward to both Fiscal and GNC in August and September, and was tabled for several months before we could even get it off the table to start the process. So yes, there has been tens of millions of dollars allocated to our state to fix our IIS system. The department's challenge is shepherding it through the different authorities, the elected authorities, to be able to stand up the correct system.
Representative Nelson.
Thank you, Mr. Thank you, Mr. Chairman. My question, you sort of touched on earlier, the numbers that they report on TV seem somewhat inaccurate. When they report, say, 3,000 new cases, that does not, just clarification, they do not count the home tests, but where do they get that number for 3,000 or whatever.
Sure.
Thank you.
Commercial labs and healthcare providers are obligated to report to public health. So we have electronic reporting from all of our labs across the state and nationally. And then all of our healthcare providers, our hospital also electronically report. So that 3,000 number, which is usually an incomplete number because we have such a backlog now. You know, we set up a system to report, 500,000 cases a day. Now we're getting 3,000 cases a day, so we're backlogged. So that 3,000 number would come from our electronic lab reporting system for all the labs and the healthcare providers across our state.
Thank you.
Yep.
Representative Soloway. Make it 5. Or you can use up any leftover minutes from Representative Edwards. Would you share?
It's all.
Rock
mine
on.
is yours.
Do I have audio?
And
Excellent.
video.
Thank you, Mr. Chairman. Thank you, Commissioner. My intent is at the end of my observations that you will simply nod and say yes. These remarks are for the public and for this committee to consider. I need to give you a word of background, please. I'm Jeffrey Salloway. I'm state representative. I have a PhD from Boston University in medical sociology and organizational development. That's going to be relevant later. In addition, I've done postdoctoral research at Tufts Medical School, and I've held fellowships at Princeton and the University of Minnesota in epidemiology. I am now Professor Emeritus at UNH, former chairman of the UNH Department of Health Management and Policy. For 20 years, I did research and taught epidemiology, and before that, I taught at Rush Medical School, University of Illinois College of Medicine, and the Medical College of Wisconsin, which should indicate to you by now that I have trouble keeping a job. Some 40 years ago, I had a colleague at Cook County Hospital in Chicago. China had just opened up to the west, and my colleague's wife had traveled to China and returned with a stubborn pulmonary infection. It was unusual. It was not an infection commonly seen at Cook County. It was a fungus. It was aspergillus. And we had no effective treatment. My colleague's wife passed away. For me, it was a wake-up call. I realized that there are infectious agents out there that we do not prophesy, and they can be lethal. So I began to watch. Later, in about 1990, a new book came out by Laurie Garrett. Laurie Garrett was a journalist for Newsday. She published a book called The Coming Plague, Newly Emerging Diseases in a World Out of Balance. Her thesis was that we were beginning to see not just an epidemic here and there, or even an occasional pandemic. Rather, what we were seeing, she wrote, is waves of infectious disease following in shorter and shorter sequence. If you think back, you will recall all of the examples: tuberculosis, polio, HIV, avian influenza, SARS, sudden acute respiratory syndrome, drug-resistant gonorrhea, and now COVID. But what has caused this continuing series, these waves of infection, is something that we had not previously anticipated. In the course of evolution, there has emerged what we might call a rogue plasmid. A plasmid is a circle of non-chromosomal RNA which carries within it instructions for cell behavior. Think of this as an operating manual for the microbe. This particular plasmid seems to carry 4 characteristics: rapid replication, an internal protein pump which enables a cell to eject foreign proteins, such as drugs, the ability to aid the human immune system, in fact, to outwit the human immune system, and finally, and most terrifying, I think, the ability to move. The plasmid moves not only from species of one kind or another, but across phyla, to move from the bacteria to the viruses to the fungi, and to confer the infectious ability on whole new orders of microbes. There are numerous alarming examples of this process. Some blame overuse of antibiotics for drug resistance. I believe that is true. However, I suspect that the emergence of highly resistant strains of bacteria and viruses is not just overuse of antibiotics. The microbes are learning to adapt to us, and they evolve faster than we can adapt to them. If you look at the example of tuberculosis, those of you who are old enough will remember when Selman Waxman discovered streptomycin in 1944, we believed that we had a cure for this scourge and that it was over. We did not prophesy the evolution of drug-resistant tuberculosis and then multi-drug resistant tuberculosis and now extremely drug-resistant tuberculosis. We call it XDR-TB, extremely drug-resistant tuberculosis. This strain is now rampant throughout Russia and is spreading westward toward Eastern Europe. Laurie Garrett then wrote Betrayal of Trust, her second book, and in it she examined public health systems worldwide. Her predictions, her prophecies were predictable. Our current public health systems are so underfunded, understaffed, and, forgive me, incompetent that they betray our trust that they can safeguard our public health. I've taken a close look at the guardians of our public health. The World Health Organization is underfunded and incompetent to meet the challenges that is upon us, and it is corrupt. Here in the United States, I've worked closely for decades with the FDA, CDC, and NIH. I avoided the FDA as it became a creature of the drug industry. I resigned from study section at NIH when I watched the old boy corruption of investigators who were funding their friends. Though I have had a love affair with the CDC, I've watched the destruction of morale and the compromise in the commitment to scientific integrity in favor of political expediency. As for our own New Hampshire Department of Health and Human Services, I have worked closely with that department for over 30 years. I've done work for them, they have done work for me, and in all those years, I have never, not ever, found either incompetence nor a whiff of corruption in any member of that organization, not ever. However, here in New Hampshire, we do not provide that department with the necessary resources to deal with what I am prophesying is coming plagues. We are not a poor state, but we are cheap. A doctoral degree from Boston University confers on one the privilege of donning the red robe of prophecy, Mr. Chairman.
Yes, sir.
You have heard the words of some who bear the burden of those red robes. We celebrated Martin Luther King's birthday just a few days past. Some find that burden unbearable and seek escape and prefer to remain silent. I can no longer remain silent. Here today, I must speak out. We did what we could in COVID, but we did poorly and we continue to do poorly. We are unprepared and will be so for the next round of infectious disease. We need to be proud of our Department of Health and Human Services, but we need to do better. So what's coming? What's down the pike? Possibly mutations of COVID. This probably isn't over. Likely, we will see 2 new variants of avian influenza, one coming our way from the Middle East and one from China. We will see Nipah virus. Most assuredly, we will see, and we are seeing, drug-resistant fungi. They are here now. They are in our hospitals now. Nobody in the hospitals wants to talk about it, but they're here. We have drug-resistant Clostridium difficile. This is old news. You've already heard about that. It is imperative that we find a way to strengthen DHHS to help prepare for what is prophesied. We need prevention, we need surveillance, we need quality data, we need the availability of treatment for all. So, thank you for listening. Thank you, Mr. Chairman, for the privilege. Thank you, Commissioner, for putting up with me. I can only hope that New Hampshire will find ways to deal with what's coming. Thank you all.
As one possessing a doctorate from Boston University, I am prepared to grant continuing education units to anyone in the room. Anything the commissioner might like to do besides nodding?
Thank you for that.
We're in this together, folks. Yes, Representative Edwards, you still have a few minutes left.
Okay, so I just received a great education there, and as I'm thinking through that, I'm thinking about the military. Whenever, you know, somebody brings a problem to the table, they're supposed to also bring a solution. And I heard in there a solution from Professor Representative Salloway that suggested that we needed to build out the public health section of our department. Do you have any initiatives underway to actively look at the kind of resourcing that would be required to at least begin moving in the direction Representative Salloway has laid out?
We have the general infrastructure in place. For example, we have the regional public health networks. Unfortunately, they are dramatically underfunded, under-resourced. They're not able to do the work that they're supposed to do. Now, during COVID, we increased their funding. We gave them the resources. They went out and ran a lot of our vaccine clinics. They did a lot of our testing. They do a lot of our school-based clinics for our kids. So they have the ability and the desire to go out and do the work they do. We just don't fund them enough. And I think that extends right into the department. So our Division of Public Health, when we were at our max of doing contact tracing and when we were trying to track COVID in the communities, you know, we went from a staff of having 10 or 12 investigators to having, you know, 150. And we had to get temp staff and National Guard staff to help us. So, yes, we have the infrastructure and we know what to do, but I don't think that the funding is there beyond COVID. Right now, we're using ARP dollars to be able to fund the work that we do. We accept the federal funds that come in, that helps. So we have the $9 million workforce grant, which puts people in the community. That's where public health needs to be, not the prevention and the fighting needs to happen in the community, not on Hazen Drive and Concord. We are one unit, but we need to have our community, our public health workers in our community, with the people, the vulnerable populations. So the answer is yes, we have the infrastructure, but we don't have the funding or the resources to stand it up in its fullest ability.
One follow-up.
Does this feel like a $10 million a year fix or a
No.
$100 million a year fix?
Definitely not
What's your
10.
instinct on this?
I would let's put it in the middle there. I don't think it's 10 million by any means. I mean, we saw how fast we spent money during COVID. I think we spent, you know, $100 million in the first 6 months of COVID between PPE and temp staffing. So in normal, non-pandemic times, it is not 100 million, but it's probably closer to 50.
Do you sense we will ever get back to normal times absent any coming pandemic?
Do I think we're going to exit the pandemic? Yes, but I think as the representative said, that we're always going to be under threat of some kind of public health risk, whether it be COVID or drug-resistant fungi or something like that. I think we need to be prepared for that. And we've seen that through the years with different respiratory viruses that have made its way through our community, not as scary as COVID, but still pretty scary.
Being staffed and prepared for it seems to me to be far preferable to a panic, oh my gosh, do we ever have to ramp up at the next emergency?
You know, I think, you know, our disease investigators, Dr. Daly, Dr. Chan, both that worked at Public Health. Dr. Daly has moved on to a national position now, but, you know, I remember our first days of the pandemic, you know, sitting down with them and saying, this is your World Series. This is what you've been preparing for your entire professional career. And we had very, you know, they're very competent, very knowledgeable people. Our state was very lucky to have their skill level in such a small state. And I think they did remarkably well. But you're talking about having a dozen people running a pandemic. I mean, the same people that runs this pandemic are the same people standing up our mental health system, are the same people dealing with the SUD crisis, and same people dealing with, family planning. It's all the same people. So even the staff at the department are gonna burn out. I mean, there's two years of this heightened, reactive crisis work standard that we have endured for 2 years at public health and all over the department. So yes, let's hope the pandemic ends.
Representative Marsh.
Thank you, Mr. Chairman. And I just wanted to point out that one of our public health partners is the town health officers, and that we are making efforts to ramp up our interaction with the town health officers, and we have our agenda later today, a report from the Health Officers Association. So I think that is part of the solution, and we need to remember that.
Okay.
Thank you so much. Next on the agenda, Federal Public Health Emergency Enrollment Unwind Update. Associate Commissioner Christine Santiello. And we'll see if that microphone's working there.
Can you hear me? Oh, it
Oh,
does work.
wonderful.
Yay. Thank you so much. I'm Chris Santinello, and
Good morning. For the record, Henry Lippman, the Medicaid Director.
And you had your vacation postponed. I'd like to believe because you wanted to be with us, but we know the real reason.
so I shared with you all a really big packet, but we're not going to go through all of that today. You have a big agenda beyond us. What I think we want to just give you some high-level information on the continuous coverage of Medicaid, but also how we're handling the end of the continuous coverage, because that's really going to be important to you all of you on a budgetary impact.
Chris, let me interrupt for 1 second. We got so many piles of wonderful stuff. What does it look like?
That one that you're holding.
Does it look like
Yep,
this?
Yep. We're not going to walk through it all. We're going to skip all over it to confuse everybody.
Thank you.
But we just want you to be aware of the potential budget impact, as well as what we're doing today to help your constituents, because we all know that you will probably be hearing from your constituents. Just on a high level, we've really been working with many partners, and internally, we've been meeting weekly since July of 2020. Every Friday at 8:15, if you need Henry or I or our teams, we are on a weekly call to talk about what we call the unwind. And our goal is to really ensure those that are eligible for Medicaid don't have a gap in coverage, because if people don't fill out the paperwork and comply with our requests, they will have a gap in coverage. But also transition those who will no longer be eligible, to really work with them to transition them to other coverage. And we have a lot of partners that we've been working on. So Henry's going to talk now about the numbers.
Chris, before I do that, you might want to just speak for a moment. Make sure everybody knows what we're talking about, public health emergency. That's a federal declaration started under President Trump. Has been continued under the new administration, President Biden. But basically, it's the declaration that allows the federal government to provide additional federal matching percentage, which is currently 6.2% reduction in what the state share is. And within the public health emergency, the department had the option to sort of scale back what it was doing, and maybe you might speak to that.
Sure. We did have the option to scale back some of our work, but we never stopped. We continued to process applications. We continued to do redeterminations as they were due, in the sense that we wanted to keep people covered. Even if we did our redeterminations and the person was no longer eligible, they continue to be eligible. So we never stopped working. We continue because we're integrated eligibility. So if a family comes in and does their application for SNAP, we immediately look at their data they're providing and try to continue their eligibility for Medicaid. So we were all systems go, and we continue to be doing that as we continue to work through all of this.
So I'd like you to, in the packet that's been passed out, jump out to slide 7, because I think this, in a small picture, describes why we're here today. Today, on slide 7, at the top there, just above the 2 circles, the Medicaid population as of last week was over 235,000 individuals. Is everybody with me? And what we've shown here are 2 circles here. The important part on the left-hand circle is the 86,038 individuals who are at risk of losing coverage. And then on the right, we have that broken down into nearly 29,000 people who we know, based on information the department has on hand, unless the individual has a change in circumstances that we're not aware of, that would lose coverage at the end of the month in which the public health emergency ends. And the population that's on in your gray spot there, we've been working with the insurance department on, and the navigators, to make sure that they're aware of their options, because there's nothing we're going to be able to do if their circumstances aren't different, other than that they're going to drop from Medicaid coverage. There's, on the left-hand side of that right-hand circle, is the 57,000 plus individuals today who are have an overdue redetermination. While we continue to do the work and continue to process redeterminations, individuals during the public health emergency are not required to do it. It's a voluntary thing. And what we've been messaging is that it's smart, if you will, to take the risk out from your family situation of not having coverage by doing the paperwork that you need to do now, because at some point there's going to be a huge influx of people, that all at once that are going to need our help. And what we've been trying to work on since July of 20 is to spread that work out so we don't have this huge tsunami of individuals needing help all of a sudden, and we're not able to respond to that. And as Chris talked about earlier, we've been working with all sorts of stakeholders in getting them to work with beneficiaries to navigate this. And it involves, for example, our MCOs, it involves the mental health centers, federally qualified health centers, anyone who has a relationship under HIPAA where they can use information. We've actually been providing information to those entities that in a compliant way that allows them to do reach out. And most recently, the department has implemented a program where we're making outbound calls to individuals who are the most at risk, the most vulnerable, people who are in long-term care. And I know you're going to talk a little bit more about that. Maybe you might want to do that now.
Yep. So what we've been doing is, because we actually, through fiscal committee and Gopher, we had some additional funding. We've been able to add call center staff so that when calls come in, they are triaging the calls, which has freed up some of our department staff to process applications. We've also used those staff to do outbound calling, to call some of our individuals that we know are behind on their redetermination, and we consider them to be vulnerable. They may be elderly, they may be disabled, and doing outreach calls. And doing those using our family service specialist is, when the family service specialist gets the person on the phone, many times they can process their redetermination while they have them on the phone. So that has been extremely successful. We've called 87% of people on a list, and we reached 38% of our target population. And so we keep on going back to making those phone calls. And at the same time, we're sharing this information publicly. We're doing, through our social media posts, working with our stakeholders to say it really is us calling. We're calling, we want to help you get through this. We're doing everything we can to try to help people remain eligible so that, as Henry said, when the end does come, which we don't know when that is, we are continuing to plan, not knowing when that end date may be, to just be better prepared.
So in terms of, if you look at slide 8, it's sort of a breakdown of the population within Medicaid over time. If you kind of look at it from just since the start of the public, basically the March 18th, I believe, is when the state of emergency was declared. Our population has grown by about 57,000 individuals enrolled in Medicaid. We think that, and this is an estimate, that approximately 23% of that extra enrollment are people who are new to Medicaid, and about 77% represents those who are what we call protected status because of the public health emergency with continuous coverage. And so I think that, we're going to see a drop in the number of people covered by Medicaid. What we just want to make sure is that it's appropriately done so that when you are thinking about this in terms of the constituent calls you might be taking, that we're helping the people that need to be helped, and when you're thinking about it from a budget standpoint, that we're doing our job in terms of making sure that eligibility is appropriately being redetermined. And so we take some questions, I think, at this point.
Yeah, I had heard that there was a Senate bill that helped people who were in danger of losing coverage. Either Senate, or if you know what I'm talking about, I'm not quite sure I do.
You'd have to provide me some more information.
Okay.
I do not recognize it from what you've said.
The only one I know of is extending postpartum
Yes.
coverage. That could be the one you're thinking of.
I
Could
think-
I ask a question?
I think so. Yes, yes, please.
Thank you. Of the 57,000 people who are overdue on the RED, how does the department have an expectation of how many are going to be ineligible? I'm trying to get a sense of what you think the total caseload is going to be reasonably, within the emergency ends, but separately, how many children do you think we're going to lose?
So we, in fact, this morning on our 8:15 call, we're starting an outreach campaign to start to call families where, starting with the youngest and most vulnerable, making outbound calls. We did that with the disabled and the long-term care people. It is a concern that those children don't lose coverage. In terms of predicting the overall, I think that we're going to get back to a somewhat pre-pandemic level at the end of the public health emergency, but it's affected, honestly, by the federal policies in place. For example, back in the beginning of 21, it was our understanding that we would be able to use information that we had that was as old as 6 months to be able to make redeterminations. More recently, the guidance has changed in August of this past year that we have to do a redetermination on everybody. And that we can only reduce from coverage with the Build Back Better Act, which was another potential change in what we could do, that we'd be limited to how many individuals could be disenrolled in a given month to, I think, 1/12. Right now, the Build Back Better component that isn't moving legislatively. As it stands right now, I think it would take us approximately between 3 and 6 months to get back to a normal level. It depends on what the runway that we're working on now in terms of all the outbound calls and all the other activities that we're doing.
And in addition to that, Senator, some of those children are eligible for SNAP and TANF, and so we use that opportunity because those are not under continuous eligibility. So we use that interaction and that data when we meet with those families to also look at the Medicaid pieces. So while we have them to say, can we continue to push them out? In addition, we're working closely with the New Hampshire Children's Trust as the facilitating organization for the Family Resource Centers, and providing them as our partners with information, showing them how to work with families in New Hampshire easy. So we're really trying to work with all of the natural community partners as to where people will go and providing them information. And our message is really simple. Please do it now so that we can keep you covered, because we don't want people to have a gap due to the high number of applications and redeterminations coming in.
Follow-up.
Follow-up, thank you.
But the TANF caseload has been low.
Yes.
Because of stimulus
Yep.
payments. So what is the department doing to automatically re-enroll people who will be eligible as soon as outside sources of?
We can't automatically enroll people. People have to either be eligible or not eligible, but we're continuing to work. We have a whole page on our website called, COVID, the Pandemic Unwind, and really trying to connect people. And I think one of the silver linings of all of this is the increased communication, and because we're integrated, we'll be saying to providers, okay, we're here talking about Medicaid, but here's other programs that we need people to continue to apply for. We're working really closely with New Hampshire Employment Security and their staff, and really just trying to work with everybody who touches a family to provide them with this information.
Fine, we'll follow up. Thank you. So going back to my first question, does the department, I think I inferred that you think we'll get back to a fiscal year 19 caseload. What about the number of children that could lose health insurance coverage?
I don't have an exact number on children that I think would be the case, but I think, our enrollment in children has increased during the public health emergency. We're certainly going to make that a very high priority, that if there's a child that's eligible, that we've made multiple attempts to get to them. But in terms of just the enrollment number, if you think about that approximately 23% of the growth in enrollment, if that were to stay and nobody were to change, we'd probably end up about 10,000 or so above where we were pre-pandemic. And I think that, again, it's going to depend on what federal policies are in place in terms of what our flexibilities are. If we're limited to, for example, only disenrolling 1/12 at a time, that's going to be a different unwind. Also, just to mention, in addition to the numbers that are here, the state of New Hampshire, through the public health emergency, what we call the COVID testing group, it's now the COVID testing and treatment group. There are approximately 9,000 individuals today who are in that group above this, but their coverage automatically ends at the end of the public health emergency. If you kind of think about that group, it's sort of the public health group in the sense that they're making sure that people are getting tested and treatment. And that one was the only eligibility for that was that you're uninsured. And so that group more recently has also had access to treatment, which is a benefit to everybody when you think about it from a public health standpoint. But there's a lot of work to be done here, and it's the most important thing from doing the mission of taking care of people, but it's also the most important thing, I think, in terms of managing the state budget with respect to Medicaid.
Representative Edwards.
Thank you, Mr. Chairman. I don't remember exactly when I first saw the IT strategic plan, but one of the priorities for early adoption and upgrade of an upgrade was the eligibility module. And as I'm listening to your struggles with trying to process eligibility issues, it makes me wonder what the status of that IT upgrade is for the eligibility module, and if that upgrade's going well, if that's going to help you work through this enormous workload.
So, yes. And we're always looking to make improvements to our New Heights system because, again, that is our integrated eligibility system. I think, unfortunately, because of the public health emergency, we've had to do a number of different programs and different services. So in an effort to respond to some of the community needs, such as like pandemic EBT, some of this Medicaid unwind, some of our regular work towards enhancing the system has gotten delayed, but yet at the same time, we're making enhancements all the time because of the public health emergency. So we're moving ahead, but we still have work to be done.
And I guess I would say also too, in terms of working with our vendor partner in this respect, that what we're able to do in terms of preparing for this, I think I put New Hampshire's status up against any other state in terms of being prepared both to help beneficiaries and also to complete an unwind.
Thank you so much. The next agenda item is one that is mine, and I'm going to wave it off so that we may devote as much time as we have to the subsequent items. System review of complaints about Nashua Children's Home, Mariah O'Neill, Child Advocate, Office of the Child Advocate. And we have reports from you that look like this, and I believe they've been handed out. Does it look like this? Another one? Oh, boy. Thank you. Extras.
Good morning. You can hear me okay?
You may want to get closer to the mic. Just keep in mind that we're broadcasting and recording, so it's important to pick up your voice.
Okay. So this is a good sound check here?
Better.
Okay, thank you. For the record, my name is Moira O'Neill. Mr. Chair, thank you for having me today to speak on behalf of the Office of the Child Advocate and make comments on our report on the Nashua Children's Home. To start with this morning, I'd just like to do an outline about the Office of the Child Advocate's mandate, the framework under which we conduct reviews, our methods of review, and then I'll walk you through a very brief summary of the prompting complaints and incidents and subsequent analysis. I understand that you've had a copy of this report already, so I didn't think I needed to go thoroughly through this. It's a 30-page report with responses on it. If you prefer at any point that I just answer questions, I'm also happy to do that as well. So the mandate of the Office of the Child Advocate is that we are an independent and impartial state agency statutorily mandated to oversee state-provided and arranged services for children, to assure the protection of their best interests, and to promote effective reforms. RSA Chapter 21V is our guiding statute. In terms of the framework under which we operate, you can imagine that independent oversight of publicly provided services is complex. There is plenty of research, including my own doctoral study, that demonstrates imposing investigations and adversarial relationships are not successful in achieving long-term change. The traditional approach to oversight that employs blame and shame that generally results in someone getting fired or a program being shuttered is only a short-term fix. There are broad and complex systemic factors that influence individuals and their decision-making. When you fire someone, the system problems that allowed that person to operate the way they did remains, and the problem is not solved. And you're left with difficult relationships, making it hard to engage folks in change and quality improvements. So with that understanding, the Office of the Child Advocate has instituted a framework of safety science to conduct our reviews and guide our relationships and oversight. Safety science is an evaluative science used in safety-critical industries like aviation and nuclear power. It has no tolerance for error, but it holds the system accountable rather than any one individual who's operating in a faulty system. With safety science, we create a safe space where people can comfortably see the value in honesty, self-examination, and constant learning. When people feel safe reviewing actions and events, they are more willing to be honest about those events and decisions made. In that space, people are empowered to problem solve with long-term solutions. It's an approach that actually improves practice in the process. So the biggest obstacle to this approach is when people are unable or unwilling to see the value of open, honest examination of events. Taking a defensive tactic to feedback closes doors to opportunities for learning and therefore improvements. None of this will work if people don't believe we can always do better. So I appreciate your indulgence in letting me explain that framework. We're very aware that our approach is different than other forms of oversight, such as licensing and special investigations, both of which have very different mandates through narrower lenses. So the method of our review, typically when we receive complaints or we notice trends in incidents that are reported to us, is that we wait for systems to play out. We hear the goal is not oversight of the program, but oversight of the internal mechanisms of system oversight, including licensing, special investigations, and general casework. If we observe that processes that are given attention to practice and events thoroughly, then we may not see a need to proceed with a review. Our first step is to assess the credibility of complaints. This we can do by reviewing immediately available records of cases or investigations. We want to be sure that complaints are timely, relevant, and associated to some established obligation for provision of service or standard of practice. Sometimes the complainant may appear not credible. For example, you may hear that complainants are disgruntled former employees. Our focus remains on the credibility of the complaint and not the complainant. Once that's determined and we have concerns, and also in the context of our own available resources to conduct a review, we may bring the complaints to the program or agency to gauge their response and assess whether they might not be able to address the complaints internally. If we find we have to proceed, we employed our statutory authority to access information and begin review of all available records, policies, program descriptions, relevant state and federal laws, contractual obligations. We conduct interviews with relevant parties and experts. We visit or observe photos and videos. We conduct literature review of standards and practices, models of care, and outcomes of both. So that gives you an idea of a sense of how we conduct a review. So before I launch into the details of our review, I want to make clear that Nashua Children's Home is not the only residential facility for which the office has received complaints or observed troubling trends in critical incidents. Please keep in mind, we are still a very new agency. The first review of any kind is going to stand out. It should not be assumed this review is any indicator for measuring comparisons with other programs. So the Office of the Child Advocate's review of Nashua Children's Home was prompted by two sources of concern. We began receiving formal complaints about Nashua Children's Home on March 2020. that accumulated to about 7 complaints. I use the word about because in addition to those we examined carefully, as we spoke with people and it became known that we were looking at Nashua Children's Home, there was a snowball effect of either additional complaints along the same themes or general encouragement to proceed with the review because of ongoing concerns with the facility. The second source of concerns were noted trends in the incident reports that the office receives for all facilities, in particular as pertain to the use of physical restraints, including prone, face-down physical restraints. We followed the process I just shared with you. We met with the program director. We shared some complaints to determine whether he recognized them as problematic and how he was responding to them. With persistent concerns, after speaking with the director, we met with the president of the Nashua Children's Home Board of Directors and subsequently sent a summary of concerns to all board members. Throughout this process, we used themes of concern that emerged from the complaints and incident reports as a reflection of a general program culture. We asked the question, does this action reflect the program's values and education of staff on the latest knowledge of child development or trauma-informed care? We asked, do the actions that are subject to the complaints reflect the mission of the organization? The response received from the director and the board was mixed. We appreciated some change in policy and promises regarding staff training. The commitment to pursue accreditation promised that some program changes would be required. But we did not get the sense that the program leadership either understood or embraced the deeper meaning of the concerns as they affected children. In the meantime, in June 2021, Nashua Children's Home signed a contract to provide residential services with DCYF. This was a groundbreaking event for New Hampshire. Prior to that moment, the state never formally contracted for residential services and therefore was never in a position to hold providers accountable to certain standards or types of care. We saw in the contract an opportunity for a good framework for reviewing the concerns from Nashua Children's Home, and it turned out that we could categorize complaints and incidents to match requirements in the contract. This would give clear path for improvement for going forward. And as a reminder, the Office of the Child Advocate does not have enforcement power. We are completely reliant upon the good faith of the department and the program to recognize the value of examination and learning to assure that the best services are available for children and that services don't further harm children. So there were 3 major themes that emerged from complaints and incident reports. They involved trauma-informed care, orders of authority, and permanency. So we reviewed certain Nashua Children's Home practices that were associated with complaints for their negative or adverse impact on the child. That they included isolation or removal from community, physical restraints, and certain staff interactions. In examining trends in the use of physical restraints at Nashua Children's Home, we noted the practice of isolating children from their peer community that appeared to be an antecedent in incidents of physical restraints. As a means of both calming and punishing, the Nashua Children's Home removed children from their peer community to a space referred to as the quiet room. They do not report using seclusion because to circumvent the statutory definition of seclusion, they post a staff person in a room containing small stalls where children are placed. Staff refer to this as extended separation. The dual purpose of the room may be therapeutically confusing for children. One former resident told us children hated the room, and that was evident in a random sampling of 54 restraint incidents, 83% of which involved a threat or a move to the quiet room. In addition to trending use of restraints, we examined experiences of 3 children who were restrained, 1 for 80 minutes in a face-down prone position. In terms of the staff interactions that we felt were associated with trauma-informed care, we looked at a child being repeatedly told he was just a kid in treatment that no one cared about, and another whose image was posted on social media in a demeaning way that may have been referencing the child's medical condition. Nashua Children's Home reported the posting was not considered a problem because they had no policy at the time against people exposing children's images on social media. Upon complaints from the staff, a policy was established. To gauge the program's appreciation for the violation of confidentiality and the potential trauma of public exposure, we asked to clarify whether the policy was established because staff complained or because it was the right thing to do. We were told it was created because staff complained. To all three types of practice complaints involving trauma, the facility response seemed to, 1, distract from the lived experience of the child, and 2, dismiss all of what we've learned in the past few decades about the impact of trauma and adverse childhood experiences. Specifically, keeping connected, not isolating, is the most effective intervention to promote resilience and inspire positive behavior. Children must feel they're valued as part of a community. Loss of control and physical restraint exacerbates trauma and is viewed as violence versus problem solving. The over-reliance on external control of children precludes success in nurturing internal controls and coping strategies. Demeaning or making fun of children and their circumstances in general aligns with the American Academy of Pediatrics definition of emotional maltreatment that New Hampshire recently codified as a form of abuse. We made the point in the report that understanding the law and acting within its confines is important, but that only represents a minimum standard for safety and care, not the best practice. In 2019, New Hampshire addressed that gap by codifying Senate Bill 14's mandate for all children's behavioral health to be trauma-informed and evidence-based. This is a standard that's aligned with the best practice and the best interests of children. In terms of complaints around responding to orders from authority, there were 2 orders that the Nashua Children's Home was reported not to have followed. One involved a child's access to court-appointed primary caring adult. A primary caring adult is a person who agrees to be involved in a child's life without the caring responsibility. There's a rigorous vetting process to approve a PCA reflecting the importance of the role and relationship. Nashua Children's Home interfered with the child's access to that PCA. The second case involves special medical orders that were not followed. The very clearly stated the orders said that the child should undertake a daily routine, but with purposeful privacy, and that the focus was ordered to be on the child's comfort level and not on the outcome of the routine. Instead, it was made into a reporting activity that made the child and at least one other child feel uncomfortable. In both cases, the disregard of orders reflected both a lack of understanding and communication with either DCYF or a physician. In terms of complaints that fell into the theme of permanency, the new contract that Nashua Children's Home signed with the state reflects the federal Family First Prevention Services Act that's grounded in the science of child development and trauma-informed care. The law and the contract are designed to promote shortened episodes of residential care, rapid reunification to families or community, and intensive supports in transition to permanency. This week, we examined Nashua Children's Home's census data for the current month. We saw that of 33 resident children, stays ranged from 99 days, which is about 3 months, to 1,903 days. That's 5 years. There are 17 residents who have been at Nashua Children's Home for more than a year, 9 for more than 2 years, and 5 for more than 3 years.
Dr. O'Neill, I'm going to interrupt you now.
Sure.
We are very pressed for time here. Would you sum up briefly, please? We can read all the documents.
Sure, in that section, so what I was getting at was that there were some interference or reported interference of planning and transitioning of children out of the facility. That when we got a response from the facility about that, it was notable that the director felt that children should have stayed longer, regardless of what happened to them otherwise, which may be other cases that should be brought to us. But it sort of reflected a feeling that there's a belief that children should stay in this facility for a long time, which was counter to the contract and also counter to federal law. So I did give you a graph. This is updated data that does show that there's a slight trend in the use of physical restraint in the facility. But if you are a statistical master, then you'll notice that while it's significant, we can't really explain it as time. It may just be that there's a different constellation of children there. And also the graph on the bottom demonstrates the reasons why children are restrained, the things that happen prior to the restraint. And it appears as though perhaps it's not necessarily, as the organization is starting to report more and document better, we're able to see that the reasons for using restraint may not meet the legal expectation for restraint, which is emergencies in case of self-harm or harm to others. In many cases, children are just not following rules, refusing to go to bed, and doing things what most kids do. So I can conclude there. So those were the findings. We generally were concerned about a culture in the facility that didn't quite get the necessary sort of switch and paradigm switch in culture that the contract and that the federal law is requiring, that we start to look at kids as really needing to only have very short stays in residential care, moving out and being trauma-informed and evidence-based so that everything we do for them actually helps them. When we look at kids who leave and the director points to them as their failures being because they left the facility, one has to ask the question, what treatment was happening to those children while they were there that would prepare them to leave after such long periods of time? Under the federal law, children have to be assessed frequently now to see whether or not the program is even effective. If a child is there for a year or more and still is not able to be safe in the community, then it's not a good match for the program. So I'll stop there and take questions.
Will you take questions? Yes, does
Happy
anyone have any? Representative McMahon.
Thank you, Mr. Chairman. Ms. O'Neill, just specific to page 16 on the report, and wanted to ask you what the recommendations you may have on this, and that's using social media as a update on what treatments that being taken place or comments on what can take place when it's referring to, it can be quite negative from what I've been reading just so far. Is there any recommendation that's being proposed to address social media being added out there from patients being handled at this location?
Sure, thank you for the question, the opportunity to clarify. So the Nashua Children's Home did establish a policy after this event based on staff complaints that would that prohibits any exposure of children's images and comments about them on social media. We were surprised that it wasn't thought about in terms of HIPAA and other federal laws that require confidentiality. We have state laws that require confidentiality of children and children's care. And beyond that, as I said, the laws around those sorts of things are important, but that's a minimum standard. Really understanding the impact of the effect on the child when they're exposed and trying to understand a culture that would do that to children. And we do see a lot of studies right now looking at how even parents are exposing their kids on social media and the negative effect that it has and the lack of respect that it demonstrates to the safety and well-being of children.
Follow up.
And, well, just to get a clarification here so I don't misinterpret what's being proposed, what's stated here. It said that this issue was resolved with the advent of policy and training. Does that mean it's now eliminated as an opportunity to take place going forward?
So we are told that there is a policy in place and that staff have been trained about it. We have not received other reports about postings about children at Nashua Children's Home, so we assume that that problem is resolved. There is also an absence of policy in the state level in terms of confidentiality around social media exposure that probably should be addressed.
It sounds to me like you're saying, and I'm trying to condense a lot into a few brief thoughts, but you've received complaints about this facility. You've investigated the complaints. You probably had a chat with a few staff members. You did work and you are working to change how the system is working, but nobody ever needs to be fired. Is that a good summary of what you've said?
Well, I would say that if you're looking for someone to fire, you're not looking for the problem.
That's
There
not true.
certainly are times when people need to be fired, for sure. But generally, people don't go to this kind of work with the intention of harming children. And also, there have been times when, and it's happened at Nashua Children's Home and in a couple of other residential programs where staff came to work and exposed children to using substances and doing other inappropriate things, and they were fired for that. But I would argue that there's still a system problem that allowed a person like that to be hired and not supervised and let that happen. So there's a systemic problem there that's not resolved just by firing people.
I see. Anyone else? Thank you so much. And the chair now calls a bunch of people. David, Bob, Stacy, Megan, Rihanna. And you'll have to decide amongst yourselves who you would like to, a couple of you come up, and maybe then you can tag team.
Mr. Chairman, members of the committee, my name is David Viliati. I'm the Executive Director of Nashua Children's Home. Also with me today are our Residential Director, Matt Fentros, who's been with us 13 years, and longtime Board of Directors member, Bill Dwyer. Nashua Children's Home began as the Nashua Protestant Orphanage Association in 1903. I've had the privilege of serving as its Executive Director for the past 36 years. One of the things to realize when we talk about, and I have a few comments on Ms. O'Neill's report, which I've submitted to you, our response. You have her response to our response. What you don't have is our subsequent response to her response to our response, which I want to get into a little bit. But as far as permanency goes, one of the things to realize is that we have no legal relationship with the boys and girls placed at Nashua Children's Home. We're only their 24-hour caregiver, but we do not have a legal relationship. So as far as their movement towards permanency, that's something that's not anywhere nearly entirely in our control. I do want to cite one of the things that Ms. O'Neill spoke to, which she references in her response to our response, where she says, twice in your response, you promoted lengthy stays at NCH for children, which belies an understanding of the federal Family First Prevention Act, which limits the amount of time children spend in residential facilities. If you look at the specifics of those examples, though, one case involved a brother and sister who came to us at the age of 6 and 7 years of age, left our facility at the age of 8 and 9 years of age, went to a foster family that we thought honestly was ill-equipped in terms of the physical energy to keep up with these two little kids who were a lot, honestly. 3 weeks later, and we still, though, gave that foster family a lot of input from the child's therapist, from our senior staff, from a number of other people. Those sessions involved the CPSW, involved the CASA as well. 3 weeks later, these are two kids that when they were at Nashua Children's Home, and they were with us for 2 years, lived on separate boys and girls units, but had visited with each other every single day. The dad was deceased, the mom's rights were terminated. As far as family contacts, they had each other and that was it. And they visited with each other every single day. They attended Charlotte Avenue Elementary School in Nashua. They made friends at school. They were invited to other kids' birthday parties at school. When the foster placement disrupted after 3 weeks, were they returned to Nashua Children's Home? No. They were placed in separate residential facilities, one out of state, one in New Hampshire, where they attend those facilities on ground schools. And in the subsequent 15 months, and this comes from the report of the 10-year-old girl who still calls us from her out-of-state facility, in the subsequent 15 months, this brother and sister who had daily visitation at Nashua Children's Home have had zero face-to-face contact with each other. I really don't think that's what the federal law intends when they talk about permanency. Zero contact with each other. The second example involves a 17-year-old girl who came from a family that had documented sustained substance use. She had that herself. When she was with us at Nashua Children's Home, she was employed at a Hannaford supermarket. She gained her driver's license. She was educated at a local alternative high school. which Nashua Children's Home paid for, by the way, not her school district. Nashua Children's Home funded the enrollment in the alternative high school. And the plan at that time was to have her transition to our transitional living program, which is a program for kids that age out of the child protective and juvenile justice system and can't return home and receive no financial support from their families of origin. We provide housing for those young people. We provide continuing staff support and guidance for those young people at zero cost to the state of New Hampshire or the federal government. That program is funded almost entirely by private charitable contributions. That was the plan. With 1 day's notice, she was returned to her biological family, after which she became pregnant and dropped out of school. Again, is that the intention of the Families First Prevention Act? I don't think so. So those are a couple of the examples. A third one that's not really, it's mentioned specifically in Ms. O'Neill's report, and I'll comment on it because, I mean, all of us have seen some of the news pieces on the tragedy occurring in Manchester with the 7-year-old girl. And I know Ms. O'Neill also mentioned kids missing from residential facilities and mentioned the risk that involves, that's increasing with kids being sexually trafficked. The boy that was physically restrained in our quiet room had a history of being sexually trafficked, made a move to leave that facility and be on the streets of Nashua, where he would be at risk again for being sexually trafficked. Our staff, Mr. Fentros being one of them, had to make a split-second decision. Do we allow that kid to leave and be on the streets at great risk to himself, or do we stop him from leaving? We stopped him from leaving, after which followed an 8-month investigation conducted, quite honestly, by people from either their offices or from their living rooms during the pandemic, judging people that show up at Nashua Children's Home every single day during this pandemic and bring their best efforts on behalf of the boys and girls that we have there. Mr. Fentros would be at Nashua Children's Home 8 o'clock tomorrow morning, stay until 11 o'clock at night, and remain overnight as well. You know, and that's one of the difficulties that comes up with this kind of procedure. I would say that the report, charitably, is fast and loose with the truth. We know nothing about a kid being told he's just a kid in treatment. The difficulty with some of the complaints is that the complaints were never presented to us with sufficient information in order to respond. We know nothing of that complaint. As far as the social media piece, it wasn't the case that the policy was instituted because of staff complaints, but once the complaint was brought to us, that image was taken down within literally 2 minutes. And then the procedure was implemented. There's not been another complaint towards that end. You know, one of the difficulties that we encounter is that there's a belief from not all, state workers, but a lot of in the child protective and juvenile justice field, that our type of program, and I think I speak for all residential providers, that we're an institution, an onerous institution that does not give kids the love and understanding and care that they need. Couldn't be further from the truth. I mean, these are people that show up for kids every day, love these kids every day. I mean, there's an effort going on to basically save kids from organizations like ours. I think there's a lot of other feedback that could be gleaned from talking with other people too about their experience at Nashua Children's Home and what they've had. So I think that the report really belies a lack of understanding on some of the rigors of residential group care, that we don't just care for individual kids, and when we need to sometimes take kids off of their units, it's because it's upsetting to the other kids, it's disruptive to the other kids, it's scary to the other kids. So we need to respond in a way that takes into account the sanctity of the group as well, and that people do need to then make split-second decisions. What I would suggest that you do, and I know I've quoted the report generously, is look at the contrast between Ms. O'Neill's report and look at the report that came from CARF International, the accrediting agency. Ms. O'Neill's report was based on complaints that came in from a number of different people, was based on an examination of records, never came on site, talked to me, talked to the president of our board of directors, Talked to no one else associated with Nashua Children's Home. Carf International's report was based on a surveyor spending 3 full days in our facility, talking with staff, talking with kids, observing our interactions, observing our culture. Her report is clearly stated in the information that's been conveyed to you. So, I mean, I would suggest that you look at the contrast in those reports as well. So I think that with that, I mean, if you look at when we make recommendations on what's in the best interest of kids, we're not necessarily looking at some of the statistical information or looking to see how many kids that we are able to transition to less alternative settings, to less intensive settings. We're making recommendations based on what we think will result in the best interests of that kid, what will result in them having the most productive adult life. So we're making our recommendations based on that specific kid's best interest, not looking to fill any type of statistical aggregate. And with that, I think I'll close my comments and take any questions that you might have.
Representative Edwards.
Thank you, Mr. Chairman. Thank you for taking my questions. I've been at your facility. I've walked through, and I was left with the impression that you have a lot of young energy and lives in there who are coming from largely dysfunctional situations, and it's a very difficult role that you play. And so I just, you've been leading that organization for what, 37 years?
36 years, yes.
Yeah, so other than your choice in football teams, I have a lot to commend you for that. But I would like to go back to the first example you gave us of the 9 and the 8-year-old.
Yes.
You've brought that to the committee. I think that's child abuse. And so I would like to know what the system is going to do in order to repair the damage that's being done to those 2 kids.
We would like to know that too. We were prepared to take those kids back. They left in October of 2020, and we were under the impression, because we, for lack of a better word, we fussed about it for a long time, thinking they should come back to us. We had Christmas presents already for those kids to come back a little bit later on. It was really at the objection of the CASA in this case, and supported by DCYF, that they did not return to us, and they continue, again, based on the reports of the 10-year-old girl, that they continue in separate residential facilities with no face-to-face contact 15 months later. We would take them back tomorrow, sir.
I may not have heard you exactly correctly. Who's standing in your way?
We have no legal relationship
Okay.
with the boy and girl, so we can't make that happen. They would need to be referred to us by DCYF, and in this case, you have a CASA involved as well.
Okay, thank you.
You have a what involved?
A CASA, a court-appointed special advocate.
Okay.
CASA. Senator.
Thank you. I have to say that I was really shocked about the social media posting of any resident, because to me that violates HIPAA.
Okay.
And risks really big fines. But I understand you've changed that. That's taken care of.
When it was, when the discomfort of staff with it was brought to my attention, it was taken down within 2 minutes.
I'm
And there's
thrilled about that. But I have a specific question about the use of restraints.
Yes.
We've heard there's a legal standard about when they can be applied.
That's correct.
And over the last few years, the state has made a public policy decision about the trauma-informed care of children that was done in Senate Bill 14 from a few years ago. What is the specific policy currently at the Nashua Children's Home? Are you only putting children in restraints if they are at risk of self-harm or harm to another?
Or harm to others. Having been again, one of the things, having been around a long time, I was very involved with the creation of Statute 126U back in 2010. And in fact, I demonstrated the physical intervention technique that we used across the street in the Senate conference room during the hearings on that. And if you look at the specifics of that, kids can be physically, it's appropriate to use physical intervention when there's imminent risk of substantial bodily injury to self or others. It's also, though, permissible to put hands on kids to escort them from one place to another. And there are times, and they happen quite regularly, where in the process of doing that, that child becomes a risk to himself or others in terms of their physical aggression. So that does happen. I mean, I would say that and again, as I referenced earlier, one of the challenges in working with groups of children is that sometimes we need to effect that removal of a kid from their group setting because of the effect that it's having on everybody else. You know, our numbers have dropped. The other thing I would point out about our experience, and this I think is certainly true, that we accept kids into our program that other New Hampshire programs won't accept, specifically because of their history of physically aggressive behavior. And then more importantly, we maintain our commitment to those kids despite their having intensive difficulty with that. No one likes to put their hands on kids and physically manage kids. It's the least palatable part of the job that we have. However, when we need to do that, we don't then end that kid's placement with us. I mean, those kids stay with us. We maintain the commitment to those kids. And, I mean, there's been some literature that refers to physical intervention as a therapeutic failure, which I strenuously object to, because the situation we have is this. We have kids that are referred to us that have a history of being aggressive to self, aggressive to others, self-injurious, injurious to others. When we accept them into our program, there's an understanding that that behavior is not going to stop simply by their placement with us. It will most likely continue. When it continues, and we stop that boy or girl from hurting themselves or hurting somebody else, how exactly have we failed in doing so? So what we see happening sometimes is kids come into the program, they need those kinds of controls for a while, and then those episodes dissipate. And interestingly, we find out oftentimes those kids form the closest relationships with those staff that they know will keep them safe when they're out of control.
Representative Edwards.
Thank you for the follow-up. This may be for the commissioner or Mr. Ribson. I noticed you started taking notes around when I mentioned the child abuse comment, and without predisposing what the outcome ought to be, I would just appreciate it if you could have sort of an independent review of the facts and your own professional judgment, so that we could have you share that with us. And then if I could, what can we do to help? There was 3 years ago, we had a special study committee to try to address parity in the group homes. I don't know what came of that study. Have you been getting better rates of pay?
We have, sir.
And so what else do we need to do? I think you're probably still mostly dependent on charitable giving.
We're somewhat dependent on charitable giving. When you visit the Nashua Children's Home, one of the examples I used was that I go in, I make a presentation to a group of General Motors executives, and I talk to them about their product making cars, and that if that car costs $1,000 to make, they're able to charge $1,500 for that car. Nashua Children's Home, our product is residential care and special education. If our product costs, say, $100, we charge $90 for it, or $85, and then we do write letters to you and your friends and neighbors seeking charitable contributions. Yeah. As far as what else, one of the challenges that we have right now is the staffing issue. And I think that one of the things that would be helpful is simply more appreciation to those people who, as they've put to us, can probably make more per hour. The person that pours their coffee in the morning at Dunk's probably makes more per hour than they do. and they still want to do the work. They still want to show up to work every day. It's hard to do that when they're going to be continually judged and investigated by people that honestly have never done the work. I mean, I would say that with a lot of the criticism of the physical intervention, a lot of the criticism of some of the advocacy groups, I think I'm correct in saying that for the most part, none of those people have ever been in the position to have to respond to a physically out of control child. So I think it's rather than having the criticism, how about the appreciation for the very difficult work that these people do, emotionally, physically, mentally, showing up every single day. I think that would mean a whole lot to those people to do.
Thank you, Mr. Vigliotti. Now, the chair has to do something that no chairs like to do, and that is to say, we have 3 additional presentations to make that, in order to do them justice, is going to take a while. I'm going to move them to the 25th of February and move them to the top of the list so that if somebody's presentation gets cut, it's a new one that day, not the ones of you who are here. However, I do want to continue on this because we have a few more people I'd like to hear from on this specific thing. So the designated receiving facilities, our friend Dr. Sai Charola's presentation on child fatalities, and the New Hampshire Health Officers Association annual report. With great apologies, you are being moved to February 25th. We will continue this presentation on this particular subject of Nashua's Children's Home. So thank you, Director. Appreciate your being here.
Thank you, Mr. Chairman and members.
I have 2 groups of people to call on. One is Megan, Rihanna, and Stacy. The second, if you wish, the commissioner and, yeah, if you wish. You don't have to, but I've been signaled by the person to your right who might like to speak as well. He can speak. Okay. So, next. Yes, sir.
I apologize, but I do have a commitment.
I understand.
And I will review the rest of on the video.
Thank you, Senator. Appreciate that. Chair now calls Megan, Rihanna, and Stacy, and perhaps Bob Keating too, if he wishes.
Thank you, Chairman Representative Pearson, for the opportunity to speak here, and to the committee members themselves. I also want to thank, I see that Senator Rosenwald stepped out for a moment, but I appreciate her efforts were instrumental in moving things up. Is it all right if I take my mask off here? Okay. I think I'll take it off to speak it. In terms of the time frame, Chairperson, how long do we have?
Tell you as long as you need, as long as you're brief and concise.
Okay, all right.
My doctorate from BU was in a liberal arts field, so.
I appreciate the openness there. So just in introducing myself, I'm Bob Keating. I'm a former staff member of 30 years at Nashua Children's Home as a consulting clinical supervisor. I came there at the initiation of the executive director, David Vigliotti, first as a board member and then served subsequently in that position. To my right is Rihanna Bazzanotti, who is a licensed independent clinical social worker, who is a therapist at Nashua Children's Home. We have Megan Levine, who is also a licensed independent clinical social worker at Nashua Children's Home, former, and Stacy Martin, who is a master's in social work, again a therapist at in this position.
Sir, could you give us your name again?
Yes, the name is Bob Keating.
Thank you.
As I said.
Thank you, sir.
You're
Proceed.
welcome. So this hearing is much appreciated, and that the oversight of what had been happening at St. Anne's, the previous places I had worked also for 30-plus years. In fact, that's where I met David. That's how he and I knew each other, and it's almost 40 years, in fact, that I've known David. So it's a good way of saying that in fact, that I come here in this whole process with a great deal of struggle, at least initially, in it, because I felt and still do a tremendous loyalty to the work at Nashua Children's Home. I've respected the work that David has done, much of is done over the years, but increasingly over a period of time, I felt more and more problematic. The people that I was supervising were bringing stories to me that were extremely troubling and did not fit for what I would call a reasonable standard of care. So the purpose in coming here is to hope to take a look at both the oversight system for Nashua Children's Home moving forward, but also for, in the larger perspective, residential programs in general. And I have to stop at this point in time to the oversight system. I don't know if Director O'Neill is still here. She's right in the doorway. I cannot say enough about the comprehensiveness of what she has done in looking at the report, because the conversation in here had to do somewhat with permanency and also restraint. I want to relate that we have 4 people here, former employees of Nashua Children's Home, who all left. Well, at least the 3 therapists left because of the atmosphere and the lack of responsiveness, not just by the executive director, but also by the board. And I have reached out to one of the board members who is here today, and I'll speak about that right now. So the brief history of the complaints, and remember, this group here is one of 7 different groups. There are 7 complainants here. I don't know how many people, that's not disclosed in terms of the report. So we have former employees, we have former residents, we have family members, we have foster parents, we have division workers, administrators from DCYF who are also complainants here. We have lawyers for children who are part of the complainants here. We also have legislators who are part of this process. So that's the scope of things. So to walk you through this, and I appreciate and give me a signal at times when that I'm pressing on the time element, and I know that you'll do that.
Yes, sir.
So this begins the process, at least for our group here, begins in May of 2019, and it begins. And please, you start first. At any point, jump in, or Megan or Stacy, at any point that you want to add here, because they are the people that had the direct experience. I heard it through them, and then in my conversations with the executive director on most of these issues that we're going to address. So it begins with this social media post. I want to highlight this social media post is not simply that a posting of a child was placed. That certainly is a privacy issue. This is in documents that we have sent to, if you look down the list here, from DCYF, the Charitable Trust Unit, and the Office of Child Advocate. It begins, if you have the pictures here, but it's inappropriate within this setting to show you that. But it's a posting of a young girl, 9 years old at that point. Was she? Yeah, she was 8. Okay, she was 8 at that point in time. This is the girl. She is known as Rose in the Office of Child Advocate's report. so an alias name on that. She is the girl that she had medical conditions which involved gastrointestinal tract issues. She also had been sexually abused. She is standing here you can picture this, with a staff member, a male staff member, holding up a face cloth. And the face cloth is looking soiled. And it was posted on an Instagram of a supervisor from this unit. And it said, is this makeup or is this poop? That was what? The girl looked distressed and crying, and subsequently this same girl becomes the subject of a filing around some similar issues, not on social media postings, but also around her medical condition that you heard referred to by this Director O'Neill in her report. So the problem here immediately takes place because it wasn't simply that it was a social media. It was inappropriate by any measure that this occurred. It was inappropriate that a supervisor did this, and it was liked by various staff members of that unit, and it was liked by the executive director. Rihanna and Stacy brought these concerns to the executive director, and I think you have some sort of flavor if you've read the report, and especially the addendum to the Office of Child's Advocate. It was minimized, it was belittled as being not significant, and frankly, I mean, please correct me at any point in time, there was what you experienced as an intimidating atmosphere. No? Is that fair to say?
Yes, I feel like as a therapist of this client, I presented my concern to the executive.
Excuse me, this is very important that we hear, and it's recorded, so, yeah.
From my perspective.
Close to the mic.
As the therapist of that client at the time, and I want to start off, thank you for having me. I worked at Nashua Children's Home for 3 years, and I loved my job at Nashua Children's Home. I loved my job so much until I did not love my job anymore, and it started with this incident of it being brought to my attention that my client was being shown on social media in this way. I would meet regularly with Dave. That's what the therapists do. You meet with him on a weekly basis for supervision to review court reports, caseloads, and I presented my concern to him. And it was immediately, I did not say how I saw the social media post, I just said that I had been witness to it, and that was immediately met with defense. He called out the other therapist's name who had brought it to my attention and tried to turn blame on her for doing something else. I told him that that was not my place. My concern was that this happened and that I felt there needed to be a larger conversation with the staff in regards to the clinical treatment of these children, because even if it was a mistake and boundaries sometimes get crossed between staff and what they do, we needed to have a larger conversation about this if they felt comfortable to do so. As I said that, and I quote, he said, "You therapists and your ethics, I don't buy into it." This is the continued reaction to me from this point on until I left the agency. I felt that as soon as I felt that something was against the staff, I think that's how it was viewed, that I was attacking staff, which was not the point. I had concerns about my client, and I felt that this was appropriate to have a larger conversation about it. I felt that any other clinical decision that I made until I left was met with almost harassment. I felt that I was being micromanaged. I had 2 clinical supervisors at the time. I had Bob, and then I also had to pay for another outside supervisor because his didn't count toward my licensure. I had the feedback from the 2 of them this entire time. I gave my notice because I also felt that the complaints that were being brought up, it was not only minimized, but the concerns of the staff people that were acting in these ways seemed to be getting promoted, and the decision-making in regards to how the therapist had a voice within the agency seemed to just not really be in existence. And I did say that in my letter of resignation, that I felt there had been shifts in decision-making that went against my clinical judgment as a therapist, and this is why I was leaving. Once I gave my letter of resignation, it came to my attention from another client that she had concerns for the same girl in the social media post, that she was being forced to report her bowel movements to a gentleman staff member on another unit. This very much concerned me, but of course this was from another client. I brought it to my clinical supervisor, created a plan with this client to have a non-leading conversation, which I did have a transcription of. It has been given to the Office of Child Advocate, and it did confirm the concerns of this girl feeling like she did not have a choice in the matter. She felt uncomfortable. She felt she could not talk to staff about this because she felt she would be called a liar because she didn't say something sooner. And I'm talking every day she was, from what I heard, had to make a call to a male staff member on another unit to describe her bowel movements.
So Mr. Chair, could I make a point here or a question?
Sure.
Okay, I know that when our selectmen start to deal with personnel issues, they go into closed session, that there's an exception for 91A. And as I'm listening to this, I'm not minimizing anything. I would stipulate that every criticism that's been made is a valid one. I'm just concerned whether or not, to use the legal terms, the accused is going to have the opportunity to confront their accusers and whether they have due process to introduce evidence on their behalf, because it's sounding a little judicial, and you're maybe the experience of some folks who've been on this, or you, where are we going with this? If we were to I'm asking the chair at this point, sure. If we were to stipulate that every criticism and concern were valid, I would like to know what it is we're supposed to do with this information.
That was a question that the chair will take. I'm just about ready to close the hearing for this reason. We have presented from 3 different kinds of sources to get the big picture. We're not a court, nor are we a government agency with authority. We're an oversight board, and I think we've done it. The question is, where does all of this go next? I realize it's been in the process, but I don't see it having been resolved yet. And to be fair to the executive director, to the former staff, and to Dr. O'Neill, we've got to figure out, as an oversight board, with input, I hope, from the commissioner and a few others, what do we recommend next? So I realize not everyone here has testified, but I think what we've got is enough to be able to make the best determination as we can about now what. So I'd be happy to hear, not now and certainly not as a group, from other members of Oversight as to what you think, and certainly from the commissioner and other parties with standing. So with that, I am closing the hearing on this particular item and indeed on today's oversight.
to go back and look at what their findings are from a licensing point of view. There's a difference between standards of care when it comes to licensing and filters. And filter is more difficult, I think, to capture in black and white standards. So I don't know that our licensing law is sufficient to do that. Just delve in it the same way that you can delve into it. And I want to look at the credentialing that they had done. But I think that the other commission on children's behavioral health, oversight is more in a more appropriate place for this than.
Okay, be good.
I don't know how it got here. I think that is.
And I just want to make a point, because I got cut off, and I was going to finish with an explanation. We did everything we could not to do it. We did everything we could not to make this public, because now this poor little girl literally has her and that's what we tried to avoid. Yeah, and so all we tried to do was get people to sit down and say, like, let's look at this. Like, why are these people saying these things? And then this is what we got.
Yeah, they're going to send it to Sharon Carson.
So it's going to go to Sharon Carson's committee, so that's the oversight committee, which is where it belongs, more than here. But I do think that there is going to be media play on this today, and we need to be ready to respond. So I'm going to get with Jake. We can do a review in childcare licensing, start there, or Meredith's.
But this conversation also just got derailed. You know, we're talking about specific things that are in a contract. You know, we're six-core strategies. Yeah,
Prior to
right.
contract.
So we just said, well, let's use the contract to say, like, this is what's going on, like, this is what contract compliance people need to look at. That's all we want. Yeah.
Senator Carson has an oversight committee, oversees this. So I'm going to